Hello, everyone. I'm Yifeng Yuan from Peking University. On behalf of Professor Wu Yangfeng, thanks for the introduction. And our topic is the public health values of potassium-enriched salt substitutes. That is what we would like to call it the best of best buys. So now the WHO has recommended a set of best buy interventions to tackle non-communicable diseases to save more lives for less money, like the non-communicable diseases like the heart disease or diabetes or cancer or the stroke. So the interventions include the tobacco control, alcohol taxation, and the promotion of physical activity or healthy diet. And 5 priority interventions is recommended by WHO expert committee, and that is the 5 interventions that save the most lives with the least money. And among the 5 interventions, actually, sodium reduction is one of the cheapest and the most cost-effective interventions of the best buy interventions. You can see here the data here. Sodium reduction only costs 5% per person per year to save more lives. So actually, sodium reduction is one of the best buy interventions to tackle non-communicable diseases. But actually, the progression has been very slow. The average sodium intake worldwide or in China is actually double the WHO's recommendation. So one of the reasonable solution to reduce salt is salt substitute, and what we like to call it the best buy of best, the best buy of best buy. So what is salt substitution? Salt substitute replace the sodium in a traditional or the regular salt by some proportion of potassium. So it can reduce sodium and increase the potassium at the same time with the dual action on blood pressure control without changing the flavor of the salt. So let's move back to the best buy issues. So when we talk about best buy, what makes a public health intervention the best? Actually, here we summarize 10 criteria here. 5 of them comes from the OECD's framework, the effectiveness, the efficiency, the evidence-based, and equity, and the extent of coverage. We added more 5 more practical dimensions: the relevance, acceptability, easy to do, availability, and suitability. And in the next few slides, I'll go through all of the criteria and show you why salt substitutes fits all of the 10 criteria. So first is relevance, the extent to which the intervention is relevant to global major health challenges. As we all know, cardiovascular disease is the #1 killer global and in China. So when we look back 20 years ago, we can see that the all-cause mortality rate increased steadily in the past 20 years. Maybe will continue to increase in the next 10 years. And hypertension is the most important and impactful risk factors with high prevalence. It contributes to 2/3 of the stroke and half of the coronary heart disease. And data shows that only a minority of people were under control. So actually, salt substitutes targets this risk. As I mentioned before, it reduces the sodium intake and increase the potassium intake and have the dual action on blood pressure control. So for the first one, it targets the risk, and it's a textbook example of good relevance to be a good public health intervention. And the next one is effectiveness, the extent to which the objectives of the intervention were achieved. Actually, in the past decades, multiple randomized control trials have shown that a substitute is effective. Multiple randomized control trials have shown that in mechanism, salt substitute can reduce arterial stiffness. So it is not surprising to see it can reduce the blood pressure. So on average, salt substitute can reduce systolic blood pressure by over 4 to 7 millimeters of mercury. So we observed a reduction of the new hypertension by 40% and an improvement of blood pressure control by 1.2-fold, and the reduction of blood pressure control and the reduction of blood pressure translate to the reduction of CVD risk. In SAS trial, one of the largest trial in salt substitute, stroke and major cardiovascular events has been reduced by almost 15%. And next one is efficiency, the extent to which inputs were used to achieve the desired outcomes. The cost of salt substitute is a little bit higher than the regular salt, almost 1.3 to 1.5 fold, but actually it's still extremely cheap. For salt substitute, the cost is 0.0075 yuan per gram, and compared to the regular salt, 0.006 yuan percent, it's only a little bit expensive than the regular salt. And the medical cost reducted by the salt substitute, like from the new hypertension or the major cardiovascular events, were much larger than the cost of the salts. So cost-effective analysis from the two randomized trials, the DECIDE SALT trial and the SAS trial, both of them show that salt substitute was cost saving. So based on those estimation, population-wide application of salt substitute would be not only cost-effective, but actually saving both societal and personal health cost. And next one is evidence-based. That is the strength and validity of evidence supporting the intervention. So first, there's sufficient evidence from the observational study or the randomized trial has shown that sodium intake is positively and potassium intake is negatively associated with blood pressure and cardiovascular risk. And for salt substitute, Professor Wu's research network in the past decades has conducted 8 salt substitute randomized trials with rigorous designs like the double-blind or the cluster randomized control designs in the real world. It involved over 25,000 participants, and which accounts for nearly 80 participants in the field. It involved broad population and complete outcomes, and among multiple scenarios like the home use or elderly care facilities. And there's 2 most important trials in these 8 randomized trials. The first one is the SAS trial. This is the longest and largest salt substitute trial, which involved 600 villages in 5 provinces across China, with 21,000 participants, and an intervention lasted for 5 years. And this is the only one salt substitute trial that used clinical endpoint like the stroke as the primary endpoint. And the next one is DECIDE SALT. It is the only trial that did not exclude patients with high hyperkalemia risk. It involved 48 elder facilities with over 2,000 participants, and an intervention lasted for 2 years with intensive serum intensive blood potassium monitoring. And next one is acceptability. So it is the extent to which intervention is embraced and accepted by the entire target population. So for a good public health intervention, everyone, the whole target population should be accept the intervention. So substitute, from this point, substitute stands out. Though the potassium is a little bit bitter taste, but when the proportion of potassium is less than 30%, usually people could not tell the difference. As is shown in CSS trial, participants reported the same flavor with high acceptability. And in SAS trial, we observed that in the intervention group, at the end of 5-year intervention, more than 90% of the participants still use the substitute with good compliance. And next one is the extent of coverage, that is the extent to which intervention reached the target population. So safety actually is the major concerns of salt substitute since potassium intake is increased in salt substitute. But evidence show that generally substitute is safe. So in SAS trial, it showed that all-cause mortality did not increase. Instead, all deaths decreased by 12%. And so substitute reduced all deaths, the hard endpoint. And for hyperkalemia, which is the side effects that the potential side effects of salt substitute that most people care about. So actually, we observed a slight but transient increase of serum potassium in the intervention group in DECIDE trial, but actually the slight increase risk of hyperkalemia detection did not translate to serious clinical outcomes. So for this perspective, actually, it is still safe. As for other side effects like the hypotension, hyponatremia, or impaired kidney function, we did not observe a difference between the intervention and the control groups. So, in summary, for the safety issues, generally, long-term use of salt substitute is generally safe, even among the older adults with multiple chronic disease. And another key barrier of the promotion of salt substitute is the cost. As I mentioned before, the cost of salt substitute is a little bit higher than the regular salt, though it is still acceptable, but 1 out of 5 of the participants still feel that the price is a little bit higher. But in another trial, it shows that a small subsidy can raise acceptability dramatically from over 40% to nearly 80%. So actually, for governments, just a small investment may have much gain from the medical cost. And from the perspective of public health, there were 2 strategies usually used on CVD prevention and control. The first one is the high-risk strategy that is more focused on the populations which has been diagnosed, like those which like those with the hypertension, usually used the approaches like the antihypertensive medications. And another strategy is the whole population strategy. like to use public health interventions to shift the blood pressure curve to left shift the blood pressure curve slightly lower. So actually, the whole population strategy is a more efficient way to for the CVD prevention and control, since it not just target those who have been diagnosed, but it targets everyone in a society. It targets from the children to the older adults. So salt substitute is actually such a safe, effective, easy to do, low cost, and scalable whole population strategy. And the next one is the suitability. It is the extent to which a product fits into the global and local situation. So according to the WHO's guideline, each person per day should consume less than 2,000 milligrams of sodium intake and consume more than 3,500 milligrams of potassium intake each day. But as we can see the pictures in the right side, actually there's huge gaps here. The sodium is almost double the WHO's recommendation, and the potassium intake is almost half of the recommendations. So as I mentioned before, substitute can decrease sodium and increase potassium at the same time. So it actually fills the two gaps of the nutrition intake. And as I mentioned before, sodium reduction is just a replacement, so it will not change the cooking habits of the people. So it fits the local situation. So we may ask that why we could not just restrict the salt supply. Actually, we tested another intervention in a design trial at the same time, and the data shows that participants can hardly accept it. Food flavor change resulted from salt supply restriction. They may report the food is too light, and they may add it. Then they may then add salt by themselves as a compensation. So actually, compared to salt supply restriction, salt substitutes, which will not change the flavor of the foods, have greater potential for promotion in the whole population. So in summary, salt substitutes fits all the 10 criteria of being a good public health intervention, and that's why we call it the best of the best buys. So salt substitute is just a small change with huge population benefit. Thanks for your attention. Thanks.